So I haven't introduced myself as a Erling. My name is Marcia. I'm from Brazil. I work with the Yaza cohort with one of my is also involved. I'll just challenge you on that. We're good enough to drive car, but we're still pretty bad at predicting when it's going to rain in 7 days. There's just some stuff we can predict very well. Some that should be quite simple. I mean, we're not,
you're saying we cannot predict hurricane? We predicted hurricane this year.
We can rain.
Oh, rain.
Is it going to rain? I mean, one thing is, the shorter term it is, for like weather, it's easier. And the more window of time you have, it's also easier. So I think we're in good shape with most of the scores we have to talk about like a 10 years. So within a 10-year range, I have enough time to some of the random things he's talking about. It's eventually will happen, we can do. But I think our power to get on the closer range enough to predict like a year or two is way tougher. And the truth is, which signs we have thus far of like really high risk predictors that we've seen that are not rare? We don't. What we have sometimes is maybe the napkin ring or the 3 high risk feature that we see on IVs or OCT. Those are like a 1, 2, 3, 5% of the population. So if we want to trim that to have this top of the pyramid 0 point something %, we might be able to do it at the expense of what Jack had said, a huge number of screenings to find this part. But is it really worth it? Is this really what we want? Or should we aim somewhere like longer term, somewhat lower risk, more intermediate, and say, yeah, we're going to handle the 20% 10-year and focus on that. And even more, what I think we should do, keeping that on one track, is the other side, finding the lower risk in what we're doing wrong and stop treating people we don't need. And then we go on the risking from the calcium score 0 and other strategies that we say we can find people where we're kind of sure it's not going to happen in somewhat a longer term. And I think we're better off finding the safer side than the higher risk. And that would go, like if you get that JAMA paper, I think Jack is one of the co-authors on JAMA cardiology, where they talk about the amount of obstructive disease you have prior to MI. And it's pretty flat, stable up until 3 months before. And then at 3 months, you say that goes from 30 to 60, 70%. So there is something acute that is non-linear, abrupt, that happens at some point. And their reference is something 3 to 6, 3 to 12 months. But it seems to be something abrupt, like a plaque rupture, that we're not really that good at predicting. So if we aim at that short period of time and try to get that event, unless we're on that period of time, we're not going to get it, and we're going to be wasting all the other measures that we could. So should we aim at a 1 year 50% and shut everything at the guidance close to that, or should we think about 10-year something else, intermediate, and then be somewhat more aggressive in there, but more than that, be more precise on that and kick out the ones we know are not. So we trim down to more precision. More precision doesn't mean we're going to get the 50%. Just mean we're going to kick out the ones we don't need and get somewhere in between. It might be more feasible. It might get less random stuff in.
Differently, that's what we've been doing so far.
It is, but I think there's still room to do that. We haven't been de-risking people for that long.
Yeah, but de-risking never is going to reduce MI. De-risking is a cost-effective argument.
But it's also against harm. It's not just cost. It's against harm for stuff we do and feasibility of doing what we have to do.
Your goal is to eliminate 600,000.
I think more people listen. Like he's saying some very decent.
Okay.
He's really analyzing it very
well. One thing I was gonna, if the idea is like we're gonna eradicate, then we need a good bunch of primordial prevention. And then, I mean, I would just refer, one thing I like less, you just go North Korea project. It took them 40 years, but they went from 40 pounds of butter per year per person to less than 1. So then you have to go society, and then I'll go to what Dan and Janet said. It's not, and even what you mentioned, it's not frightening the patient because, or the person, it's way beyond that. There's so much society around it. If you want to do primordial stuff, we're talking about social behavioral science, which is from advertising to getting the. here in the US, guys drive through to mail, to food, and to the bank.
Yeah.
It's just so simple, this is not gonna work. You make cities without sidewalks, and like places like, you go to LA, a block is 2 miles. That ain't gonna make, it doesn't matter how much you frighten people, that system doesn't work for what we recommend in terms of, you have to exercise, you have to walk to work, it's not feasible. So I think if we want to eradicate, we have a bunch more to do on the primordial part, but I think there's some room for the high risk, but I wouldn't aim to the very, very, very top end. I think we can step down a bit, assume there is some random stochastic thing that we can't predict, and that has to do with time. So if you give us a bit more time from the 1 year and a bit less risk, then we have a bit more room to work and then target on people that were more visible. And then I think we should model a bit less than that.
I hear you. When we wrote this proposal to Google, one of the preambles was that it's well known, and Dan Berman is a walking example, so is David, that if you adhere to all of those low-risk behavior, diet, Mediterranean diet, all that, you can reduce the attributable risk to in 97% you can break that. But when you look at U.S. population according to Enhanced, you know what percentage of U.S. population fall in that category?
It's like 1%.
No. Yeah, less than 3% of the entire U.S. population fall in that ideal risk category. American Heart has made a fool of itself for the last 30 years, saying the same thing again and again. What is going to change?
I don't know, that's what I echoed the North Korea project that you know from Finland, but they had all things wrong, and they did like, I think their last version of, I think it's Global Heart, was a whole issue about 82% heart attack reduction. So it's 82% less coronary heart disease over 40 years, basically on risk factors. And there's some interesting data in there, because not only do they say it's 80% less, I think it's a BMJ paper of 2015 where they say if you sum what we did in blood pressure, plus cholesterol, plus diet, plus exercise, and sum it up, what we got is more. So when you do everything on the right direction, you can do even more than what you predict. There's a lot of, the thing is, it works. There is places where it has worked.
I agree with you. I'm saying,
but the thing is,
we have walking examples, but in
US hasn't been able to do that thing, also because of policy, in a way. The world is seen here.
Only less than 3% of U.S. population fall under ideal risk.
Yeah. And in Brazil, it's not that far.
But I think that's a message to us, scientists and academics, to wake up and stop dreaming that we can get 97% of people to that 3%. We have to change our approach, otherwise we're just going to get the same thing. And I don't disagree that population level, the Rose approach, epidemiology, but we really need to do now. I'm not saying we're going to be able to do this 25% with the same approach. I'm relying on you honest, Piotr, IBM Watson, and our unique cohort that we have to draw something that we don't know. I'm not going with what we know. What we don't know, what do we come up with something? I mean, something happened to our patients. You just said that. Within 3 to 6 months, something happened.
I'm curious. I would expect we would define that out, but the truth is we haven't. And the only true.
Well, we never looked at it.
I
mean, everything we looked at.
It's in every 3 months.
No.
Are you ready? I was going to throw at machine learning a little bit here, because the data we have is not that good. We have a baseline measure. If you actually had heart rate variability on a per second basis, or per minute blood pressure, or stress levels on a continuous basis, I think it's possible. But we don't have any of that. The stuff that you're talking about there, all those stochastic measures, we need exquisite data. That's what you said over and over. Someone said that they showed the data going into the mouth. Right? That's, be way better data than what we have to do with your.
And even beyond that, when you look
Oh, at least you're saying we need data, so that's exactly
But
what
then
we
the data that's not in the cohorts that exists.
How do you know? I
Well,
don't.
because looking at baseline measures and brought some back in a couple of years.
If you get 2,000 of patients, samples of people who had an event within a few weeks and a month, and you delve into their blood, their imaging, their clinical information, and you feed it into machine learning, do you think we'll learn more than what we have now? So I like
I
it.
don't think we have sleep, I don't think we have stress, I don't think we have their, there's no
I think there's some missing the pieces. It's not, I don't think processing better the data we will have.
We may not have physiologic data, but I think if you're able to get the blood and do a thorough, I mean, you know that physiology is the end of the line. Between, there are a lot of proteins.
It's the data, in my opinion, if you just have a baseline blood measure, still, it's not gonna help you that
Not-
much. Just one baseline blood measure,
But
even if
if-
you measure every single person.
But if that baseline was a few days before the event, that'll give you something.
True,
to
yeah, I'll give you a couple days, I think, if you have that many.
So some people think it's a couple of months, like Dr. Bravo said, Italian professor. He
Maseri.
made a good argument that day, this is 12 years ago, that there is a wave going, and the frequency or period of this wave is within 3 or so months. You know, what's his name? Forgot. So, in his on our website, I don't know what the wave is. When I talk to the microRNA guys, they say a few days. Exosomes and other things, you know, I don't know, but I think if there is a hope, it would go through this path that we're trying to dig this unique population. A few days before the event, a few weeks before the event, they were, you know, in clinic.
What the PMI guys are doing, they're actually taking all these, that's the kind of data that we need.
PMI.
Precision,
Oh yeah, that 20 years from now, you're not going to be able to get.
And maybe they can,
Okay, we're going to wrap up. Thank you, gentlemen.
Yeah.
Erling, can we give Erling the
Start
last word?
second better.
Can we give Erling the last word? Sorry. Erling and Mark,
What do you say?
you have the last word.
Yes, I just say if you manage to find a marker or a fingerprint that can predict a heart attack in the next half year, how do you envision it should be implemented? Should all adults be tested every half a year to see what is the risk of having a heart attack next half year?
I don't know.
But it's an important question.
Yes, it is a very important question. It's absolutely.
Apple
And
Watch.
it doesn't.
And
it
that's-
works.
It's in your
That's why
Apple
you-
Watch.
That's why you always say that the pathologist always has the last word.
That's right. For mine was.
Thank you, Morris.
Thank you very much.
Morris, this was great.
Everybody online.